This is Average Joe PT, where we're here to reduce anxiety, improve function, and master your pain. Ain't that right, Skully?
Mastering your pain.
That's right. Skully and I would love to have you guys subscribe to our channel. Hit the bell down below. We bring content once or twice a week. I bring videos live Wednesday night, 6:30 Eastern Standard Time, where we talk about all kinds of things, physical therapy, and hopefully some medical stuff. And so today we're going to talk about good old-fashioned slap chairs. No, not slapping. No, not that. Slap tears, S-L-A-P, superior labral anterior posterior tears. We're going to go over what you can expect, what you can do at home, what you can hopefully get used to doing post-operatively, and also pre-operatively. So let's go ahead, you stick with Skully and me.
You're always hogging the whole show.
Okay, calm down. And we're going to go ahead and get started. Here we go. Now, did you see that crazy guy in that video? He was doing everything possibly that you could do wrong to that good old shoulder to give you a problem. What's in he, Skully?
Didn't realize it was you being videotaped.
Oh yeah, I know it was me.
Why you acting like it wasn't you
What,
then?
you think I'm dumb, Skully? Of course I know it was me. I'm showing the public, showing everybody what happens and how you injure yourself.
I was just saying.
You don't got to be so. Don't even start with a whole thing that you plan hopefully not doing today. Anyways, so let's go ahead. We're going to talk about that slap tear, S-L-A-P. And so if you go ahead and you could take this ball right off and you have that socket part, this labrum actually is what deepens so that the ball has something to fit into. And what happens is that bicep, that long head runs all the way up and attaches to the top of that labrum in there. And when you injure yourself, like I showed you earlier, you can go ahead and tear the top of that labrum and cause a lot of bicep pain in the front. Now, there's tons of research out there that says that as we age, your labrum has tears anyways and degenerates. We use our shoulders all the time. So on an MRI, it might show a labral tear. That might not be where some of your pain's coming from. It could be coming from the rotator cuff. But if you have to have surgery, because the doctor says, hey, it's bad, the one thing that you probably want to make sure that you get is what's called the biceps tenodesis. That's where they take the long end of that bicep that was hooked into that labrum and they actually snip it off and they attach it within the bicep groove here. And so you don't have to worry about that bicep causing another tear in that labral area, and it probably is going to take a lot of, if not all of your pain away from this shoulder area. And so that's the big thing. Now the other thing that they'll do, I'm going to come up real close here, and they can go ahead and they can cut this ligament here. They'll shave this part. This is called the bottom part of the acromion. They can take some of the bursa out. All right, and what the heck is bursa? We talked about this a while ago. The bursa essentially is where the tendon glides over the bone, and that bursa is usually a thin sheet of paper, and it just allows those tendons to glide over the bone without injury. But they get inflamed, they turn into big sacs and fill up with fluid, and there you go, you got some bursitis. And sometimes they have to do a synovectomy also on top of everything else. And they also sometimes have to, see that little part there? That's right, that's the distal part of your clavicle. The collarbone coming all the way up and attaching here. And sometimes they have to cut that part and shave it. And it basically allows that muscle, see it right in there, right where my finger's at? It's allowing that muscle where my finger's at to come through to the front and not get pinched anymore. And so they'll kind of, what they end up doing is it's called a distal clavicle excision, or DCE, subacromial decompression, which they shave underneath the bone here that I showed you earlier. They do that biceps tenodesis, and a lot of times you're gonna leave out of that surgery and wake up with a big pillow thing underneath your arm and a sling. That pillow thing is to help to shorten and unload those rotator cuff, and obviously the sling is there to protect the surgical site. And they're gonna keep you probably in this bent elbow position for at least 2 to 3 weeks. Now, some surgeons, they want no movement in the arm passively or actively for 5 or 6 weeks, because they want to make sure that anchor where they went in with that bicep area to anchor it into the long head, the bicipital groove area, they want to make sure that doesn't pull away. So they want to be very protective. You might be able to do a few treatments that at home. First one they should do with you is just your shoulder blade pinches together. You're not going to injure your shoulder surgery with that one. They might go ahead and have you try and do some shrugs. That's another nice one to do. And they're going to want you to move your wrists and squeeze that little red ball that they give you. And they want you to wear the ice probably all the time to really keep that swelling down and reduce the pain as much as humanly possible. So that's some real techniques that you'll need to be able to do exercise-wise when you first get out of surgery. Those first 2-3 weeks are what we call the protective phase. What's that mean?
I'm not sure I want to talk to you right
talk to
now. All right, it means you're not supposed to move.
That's right.
It
That's exactly
by yourself.
what it means. It means that you're not supposed to move that arm at all in the protective phase. You're not supposed to. The only thing you're supposed to do is make and allow your therapist to do the passive movements when you go to therapy. Yes, you won't be able to do this stuff at home. You'll have to see a physical therapist to do the passive motion and progress you through the protocol that the physician will give you. The most important thing is making sure that you're not doing anything to that bicep for at least 6 to 7 weeks. Sometimes the surgeon might make it longer. Sometimes the surgeon might make it shorter. It all depends, obviously, on the surgeon, but that's kind of the window. They want to make sure that where they anchor that into that groove area in that bone, it's staying solid. That's the most important part of your post-surgical issues. And obviously, no moving it until the doctor says so. After about 5 or 6 weeks, they're going to start moving you into active assistive. And that's what we looked at last time with the good old dowel, stick, dust wand that I used. You're going to want to start to do that, and the therapist should give you that stuff at home. So that's a technique you'll be able to do probably somewhere between that 4 to 6 week window. So that's some treatments you'll be able to do at home. The other ones that you'll be able to do at home almost right away, 3 or 4 week, is some of those trigger points. Get yourself the Theracane that I've shown in multiple videos to really work on those knots and the back side of your shoulder area. All those rotator cuff muscles that they didn't do surgery on are going to have some extra tone in there because they're supporting the entire back side. And so they all got traumatized a little bit from the actual surgery themselves. And so they're going to be inflamed. They're going to give you some active trigger points. And you want to go in there with the Theracane or the tennis ball technique that I've shown in the past to help reduce some of those referral pain symptoms, as well as that levator scapula muscle that I've shown in the neck video. That little beast, boy, attaches at the top of that shoulder blade, and the top of that shoulder blade all the way to the neck. So you can have some neck and shoulder blade pain weeks and weeks and weeks after the surgery because of those muscles that attach from the shoulder blade to the neck, and the main one being the levator scapula. So that's some food for thought for you too. So you can have some secondary issues going on in regards to this post-surgical problem that you think you're just going to work on range of motion, yes, but you're also going to have to work on the soft tissue and some of the trauma from the surgery itself, and all those muscles giving you some pain. What do you think about that, Skull?
There's a lot to the surgery.
Yeah, I know. There's a lot to it. There's a lot to it, people. And also, you're going to want to make sure that after surgery that you're going to have someone at home with you, because the reality is you can't move around with one arm. You're in pain all the time. You're not going to be sleeping well. Oh, that's right. You're probably not going to want to sleep in your bed. It's going to hurt too much to lay flat. You're probably going to want to sleep in a recliner chair that gives you some support around the entire backside and the lounge arm puffy area on the armrest. They'll help support you a little bit more than trying to lie flat or trying to lie in an incline with a bunch of pillows in bed. You're better off in a recliner chair. Don't normally say that because you might get some back pain from being in that being in that recliner chair for weeks, but you're just gonna have to weigh your positives and negatives in regards to that part. So what do you think, Skully? You think we're right on the right track here?
I think we're almost done here, people.
Yeah. We're getting through this. Slap tears aren't easy. There's 4 different kinds. It's kind of like the meniscus in your knee. It can tear a couple different ways. One is basically the most mild, and you might get lucky with that. You might not have to have surgery. That's where the bicep really hasn't torn off of the backside of this labrum. Stage 2, it's torn into the bicep. You're gonna have to have surgery. Stage 3 and 4, that whole labrum part is basically ripped off of the bone. The biceps is probably torn right off, or pretty close to it anyways. So I'm gonna leave a pic right here to kind of give you guys an idea what I'm talking about. It's 4 different kinds, and hopefully the doctor will tell you what degree, because a lot of times the surgeons don't. They'll just say, yeah, you have a labral tear. Ask them what grade you have, 1, 2, 3, or 4. Some nice info for you, folks. What do you think, Skully? Yeah? Stop talking. What'd you stop talking for? You're gonna get all mad at me. We're gonna pick you up now, buddy. Alright. Relax. If you guys have any comments, I want you to leave them below. Love to hear the comments. Skully and I would love to have you subscribe to our channel. I'm gonna leave a little pic up here. It's gonna go over some other types of shoulder problems that you can have and some treatments that you can do at home to help with those particular problems. But until next time, Skully and I want you to look up and keep smiling.